Welcome to session 8, a day in the life of a claim. Q&A, slide decks, and any notebooks that have been shared from our presentations are going to be shared on our Confluence space. So please keep an eye out there as things start getting uploaded and updated. So at this point, I'm going to turn things over to Gennady to give you some more information about his background and his session.
Good afternoon. Can you hear me okay?
Yep, you sound good.
Great. I apologize for not being in real time because my camera is not cooperating with Zoom, so you're going to have to stare at my static picture. Anyway, I will do an overview of submission, processing, and management of fee-for-service claims in CMS. And unlike the previous presentations, the most of them, this will be a descriptive business high-level presentation. It was created using documents prepared over the years by various CMS claim processing experts, and those presentations were actually multi-session and multi-hour presentations. Because when we talk about a day in the life of a claim, it will literally take at least a full day presentation to cover all details. And my challenge was to distill the documents into a 40+ minute presentation. So again, the subject will be covered on a high level. I feel it will be of interest to those who are new to Medicare claims processing at CMS. And for those who are familiar with the process, it will be a back to basics session. Can go to the next slide. And the next slide. So what is Medicare? It's a health insurance for people who are 65 years or older, or under 65 with certain disabilities such as ALS, also called Lou Gehrig's disease, for any age with end-stage renal disease, and there is eligibility to be a U.S. citizen or lawfully present in the U.S. for 5 years. And the recipients are called Medicare beneficiaries. Medicare was established in 1965 and signed into a law by then U.S. President Lyndon B. Johnson. So we will celebrate 60th anniversary next year. Next slide, please. What are the parts of Medicare fee-for-service? Part A, or hospital insurance, helps cover inpatient care in hospitals, skilled nursing facility or SNF, hospice care, home health care, blood, and Part B helps cover services from doctors and other healthcare providers, outpatient care, home health care, durable medical equipment or DME, and many other preventive services. As you can see, home health care services are listed under both Part A and Part B, and that is for a reason. Part A provides coverage in certain circumstances after a patient was in a hospital or skilled nursing facility. Specifically, if a patient spends at least 3 consecutive days as a hospital inpatient or has a Medicare-covered SNF stay, then Part A covers the first 100 days of home health care. A patient still must meet other home health care eligibility requirements, such as being homebound and needing skilled care. A patient also must receive home health services within 14 days of his or her hospital or SNF discharge to be covered under Part A. Any additional days past 100 days are covered by Part B. And regardless of whether home health care is covered by Part A or Part B, Medicare pays the full cost. Next slide, please. Now, what is a Medicare fee-for-service claim? We will define it first from the business perspective. Medicare defines claim as a request for payment for benefits or services a patient gets. Medicare requires healthcare professionals or suppliers who furnish covered services to submit claims. And from data management perspective, a claim is a data object that represents a bill for healthcare services, and it contains the following sections. Identification sections, which includes patient personal information and demographics. Diagnosis section, which provides information about the patient's condition or illness. Treatment section, which outlines the specific treatment plan, including medications, procedures, and therapies. Service section details the services provided by healthcare professionals, such as doctors, nurses, or other healthcare specialists. And billing section, which includes information about the cost associated with the treatment and how the claim will be reimbursed. A word about how Medicare claims are paid. There is a legislatively mandated waiting period for paying Medicare fee-for-service claims, which is called the payment floor. It is no earlier than 14 days for electronic claims and no earlier than 29 days for paper claims. It is that long because Medicare claims must be processed by our systems, and the systems are coming of age, so they are mostly batch type systems, and it requires a few days to process claims. And we will talk about it on later slides. There is also a ceiling period, which means a claim must be paid within 30 days after the date of receipt, and that applies to both electronic and paper claims. And CMS is actually incentivized to honor a ceiling period because there is an interest that must be paid if payment is not made to providers on time. Interest is not paid on claims requiring external investigation by contractor, on claims which do not have any payment due, and on full denials. If there is a partial denial, interest is payable on reduced amount. And the current interest rate is 4.875%. Next slide, please. We are looking at CMS data taxonomy in a nutshell. And it defines claim in terms of master data management. As you can see, we have certain domain groups, and claim belongs to mission support data domain type, which is called healthcare services. And the data category is called health service delivery. You see that fat yellow check mark next to it. It is important to know because some of you will be or have been involved in CMS annual system inventory, and we have to place each record type, each data domain in the proper place and list them as such. Next slide, please. This is briefly about how Medicare fee-for-service claims are submitted. Listed here are various protocols which are mandated and maintained by National Uniform Billing Committee. As you can see, there is a provision for paper claims as well. And almost 100% submitted electronically. Next slide. Who are Medicare fee-for-service providers? Providers are primary stakeholder group for claims processing, and they're divided into three categories. Institutional providers, which hospitals, hospital patient departments, hospices, home health agencies, and rural health clinics. I apologize for the typo here, institutional, not instructional. The next group is physicians, physician groups, and non-physician practitioners, and suppliers or others who are represented by labs, ambulance, independent diagnostic testing facility, and durable medical equipment suppliers. And they are paid respectively, as you can see in the description, from different parts of Medicare trust funds. Let's go back to the previous slide, because I wanted to, yes, thank you, mention about who processes Medicare claims. There are 12 A and Part B max Medicare administrative contractors and 4 durable medical equipment max in the program, and they process Medicare claims for nearly 51% of the total Medicare beneficiary population, which is approximately 34 million beneficiaries. And in fiscal year 2023, Max served more than 1.2 million healthcare providers who are enrolled in the Medicare fee-for-service program. And collectively, in fiscal year 2023, Max processed more than 1.1 billion Medicare fee-for-service claims, comprised of approximately 192 million Part A claims and 950 million Part B claims, and collectively paid out approximately 431.5 billion in Medicare fee-for-service benefits. If you think about magnitude of those numbers, you can get an idea of how important Medicare is and how large the service that is provided by CMS is on the nationwide scale. Let's go to the next slide. We can go to slide 11. Thank you. So we talked about who process Medicare fee-for-service claims. So in addition to processing, Medicare administrative contractors provide additional services, such as enrolling providers, handle provider reimbursement services, handle redetermination, respond to their inquiries, educate providers, establish local coverage determinations, review medical records, and coordinate with CMS and other fee-for-service contractors. Let's go to the next slide. Electronic claims processing. So there are two ways to file Medicare claims, electronically or through a paper. And on one of the previous slides, I mentioned that claims have several sections by topic. And this is essentially a crosswalk to loops and segments that is established by American National Standards Institute. It's just for your information. You can look at it for a moment. I think it is self-explanatory. We can go to the next slide. This is a very high-level data flow of claims through primary Medicare claims processing systems at CMS. I inherited actually this diagram from CMS experts. It is a little aged, but still valid, and it contains some extraneous information which we don't have to focus on, but I will explain what is of essence here. So about the legend, as you can see, circles represent people, rectangles, whether rounded corners or not, represent systems. And I will explain to you also why in the center you see that there is an obfuscation of EDB and SSA. These are not really claim records, but this data flow is very important because SSA sends through EDW, which stands for Enrollment Database, Beneficiary Enrollment, and Eligibility, which is being used in claim edits. But the flow that we will be following will be 1, 4, 5, and 14 through 17. So number 1 is fee-for-service claims originated by providers go to MACs, and MACs, as we discussed in the previous slide, depending on what claims they serve, they send it to one of 3 systems. And I will briefly talk about those systems which are called shared systems. These systems are not typically accessed by end users. Systems that are accessed by end users or downstream systems on the bottom right corner, the green ones, NCH, National Claims History, CCW, Chronic Condition Warehouse, and IDR, the Integrated Data Repository. But shared systems, systems that were created actually at the end of 20th century, believe it or not, and they're still mainframe based, and they provide all the edits and adjudication of claims. Okay, let's talk about them briefly. FIS, or fiscal intermediary shared system, is responsible for processing Medicare Part A claims. They perform data collection, validation, claims control, pricing, adjudication, correspondence, and online inquiry, as well as maintenance, reports, reimbursement, and financial processing. Multi-carrier system, or MCS, is responsible for processing Medicare Part B professional claims, and VMS, which stands for VIPS Medicare system is responsible for processing Medicare Part B DME claims, durable medical equipment. And VMS actually is both batch and online system. The online claims subsystem includes validity, consistency, and eligibility edits, and claims pricing, all with automated functionality and error resolution through user-updated parameters. And the batch claim adjudication process component is where the system performs historical auditing of the in-process claim against other previously processed or in-process claims for duplicate check and prepayment utilization reviews. On the right, you see CWF, which stands for Common Working File. That is, I would say, the most important part of claims processing, because it provides a consolidated Part A and Part B benefit coordination and prepayment claim validation system. We will cover it in one of the subsequent slides. Here, I just mentioned that CWF queries shared systems on a daily basis and sends response file to shared systems and ultimately to MACs and providers, because it also incorporates a feed that I mentioned earlier from EDW that contains beneficiary eligibility and enrollment. And you see from here that there is a feed number 17. So from shared systems, Part A, Part B, and DME claims daily fed into the integrated data repository. However, Part A, Part B, and beneficiary updates are also fed through MQR and MQA. What is MQA and MQR? They stand for Medicare Quality Release and Medicare Quality Assurance System. They accept all adjudicated Medicare claims and perform receipt and control data cleansing, quality assurance, and validation, transformation, and reformatting of those claims prior to consumer use. And then via the feed number 16, they send them to NCH, IDR, and CCW. There are other feeds, which auxiliary feeds. Of note is FPS, or Fraud Prevention System. CWF sends claims to Fraud Prevention System because, as you may know, despite very extensive efforts by CMS, the fraud is still persistent, and therefore it's very important to detect it. It's typically done on a daily basis. And 7 through 12 various feeds to Eyeglass and coordination of benefits, or COB. These are essentially adjudicated claims, coordination of benefit notices, and payments data streams. Let's go to the next slide. This is really a life of a claim as it's being processed, the life cycle. Let's suppose Wednesday during the day, provider submits claim to MAC, Max sends the claim into the fiscal intermediary shared system queue. And on Wednesday night, the first night is mostly spent in processing the batch. By 10 p.m., claim is processed through the BDS. BDS is additional checks on beneficiary eligibility, and it stands for beneficiary date streamlining. It was created about 11 years ago. And by 3 a.m., shared systems sends claim to common working file. Next night, as you see, within a minute, CWF immediately forwards claims for fraud prevention check. And replies are received typically within 8 hours. And the cleared claims are received by 6 p.m. and by 10 p.m. we're into CWF nightly claims processing. On Friday, by 3 a.m., processing is done. Claim is sent back to fiscal intermediary shared system to travel to Max and to financial systems such as Highglass, and also added to CWF expert for MTA, MQR, for national claims history. And on Monday during the day, MAC receives claim response and can queue the pending payment or alert the provider that there is a reason for denial and opening them an opportunity for appeal. And from 6th to 14th day, we meet the payment floor. Payment is held until it's been 14 days since submission. We can go to the next slide. Well, this is the description of shared systems. I don't think we have to read through it again because this slide has technical details about what the system consists of. You will receive a copy of the slide and you will be able to read it. Let's go to the next slide. And the next slide. Let's stay a little bit on common working file because it's a major, as I mentioned, claim processing component. It's a prepayment claim validation, and it is distributed into 9 localized databases, which are maintained by a designated contractor called CWF host. And Max can be assigned to one or more of the 9 CWF host databases. The interesting part is the DME Max process claims using beneficiary location, while Part A and B professional claims Max use the provider location. Once the claim passes all of the edits, the CWF beneficiary master file is updated to reflect the benefits that are now available, as well as any changes to the deductible status, which is also very important. And the claim is added to the CWF full claim history file. Part A inpatient, home health, and hospice claims history remain available forever, but outpatient claim history remains available for 27 months, and Part B and DV claims history remains available in common working file for 24 months. Any other pertinent files are also updated, and claim is sent to CMS Central Office to add to the National Claims History file. Next slide, please. As I mentioned earlier, shared systems are coming of age and outdated. They need modernization. The challenges include, of course, outdated technology, mainframe, COBOL, CICS, ACLs, hard to find experts, batch processing for the most part, not real time. They are on-premise, not in cloud. Front end is not user-friendly, and it takes significant amount of time, up to 12 to 18 months for system changes. So what is CMS doing about it? CMS has created and is currently enhancing a conversion Medicare module. It's a cloud-based system that performs the initial receipt and control activity for claims data that will move through claim analysis and reporting applications in CMS and stored in various Medicare data stores. The CVM application collects two types of data transmitted to CMS by the common working file, which Medicare claims data and eligibility maintenance data, and then forwards them to consumer applications and systems. In addition, CVM system parses claims and converts them from episodic data files, reformats them into the individual JSON objects, and stores them for quality assurance processing in S3 buckets. Let's go to the next slide. So this is the first time we see our very own CDR, and the claim flows from CVM to NCH and then to CDR. And again, this is an inherited diagram. I only slightly modified it to include CDR, and it actually goes from right to left. So let's follow those thick blue lines. From CWF, as I mentioned, Medicare claims and eligibility maintenance feeds go to EFT, electronic file transfer area, in the CMS data center, which is still on premise. And from there, Medicare claims go to claims workflow, and eligibility maintenance go to CVM maintenance workflow. And as a response, we receive not daily, but weekly NCH claims, number 5 here. And these weekly NCH claims are fed into the NCH. You might be wondering why we have a split here into Medicare claims and also DME claims, which go to PDAC. What is PDAC? PDAC stands for, let me find it out, sorry. PDAC stands for Provider Data Analysis and Coding. And this is an auxiliary system module that performs additional sorting, validation, and provides some educational materials for CMS and contractors involved into DME claims management. The NCH process itself, what does it do? It still resides on Baltimore data center mainframe, and it contains Medicare fee-for-service claims data from 1991 up to the present time. Processed claims means that the institutional Part A and Part B claims, as well as DME and physician Part B claims, have been validated and payment authorized by CWF host. And again, NCH contains both institutional and non-institutional claims and serves as the source for a variety of analytical files, which are used to study the operation and effectiveness of the Medicare program. You might have heard, and some of you maybe worked with them. They're called standard analytic files, and they're typically created on an annual or biannual basis. And from NCH feeds claims into the CDR. We are currently working on bypassing NCH and receive NCH claims directly from CVM, but currently there have been some inconsistencies in data validation formats, and therefore we still resorted to receiving claims through NCH. But we are planning to be soon fed claim data stream directly from CVM. Let's go to the next slide. We're talking here about claim final action. Claim is a living document. And once a claim is submitted, it could be adjusted due to various circumstances. Most notably, diagnosis could be adjusted, sometimes revenue center codes and various procedure codes can also be adjusted. And let's look at what happens here. The claim has a final action indicator, which could be set to yes or no. So let's observe this table from the bottom. We receive claim, and first it was set to final action, which was yes. And then record number 2 was an adjustment credit. And as you can see, claim effective date is equal to claim obsolete date. And adjustment type code is 1, which means credit adjustment. So original claim, which is the bottom claim, is no longer final. On the same day, a debit adjustment was received. And that debit adjustment was now final. And then it was repeated on September the 28th. And this process goes on, and claim could be in final action at a given point of time. In this case, it is number 5 record, and it is usually denoted by claim effective date on which the claim is becoming final through the end of time, right? Now, this process is described by claim maturity. For those of you who are involved in producing and using CSAT, which stands for Complete Statistical Analytical Table, claims maturity plays an important role. In CSAT, for instance, we flag claims with 2 and 5 months maturity. And of course, in this example, this is a very short maturity period. CMS has performed extensive studies to observe and estimate the overall claims maturity cadence. More than 95% hospice, hospital outpatient, and carrier claims are completely reconciled and in final form at approximately 5 months post-service. SNF and DME claims reach this level of maturity at 6 months. Inpatient and home health claims are slightly slower matured, with about 90 and 94% of claims respectively considered final after 6 months. After 12 months, 95.6% of inpatient claims are fully mature. And this is a lower proportion than any of the other institutional or non-institutional settings. More than 98% of sleep, hospice, home health, hospital outpatient, carrier, and DME claims are completely mature after 12 months. And within 24 months, 99% of each claim type except for inpatient are final. Inpatient claims typically continue to be subjected to edits even beyond 2 years post-service. 99 completion is not reached until 36 months of maturity. Next slide. We can skip this slide because we already talked about it. This is a very important slide because it describes claim as a data object, and it is a conceptual view. As you can see, claim is connected to several subject areas: beneficiary, provider, contract, reference data. Let's briefly go over each one. So provider is identified by NPI fields, as you know, and NPI stands for National Provider Identifier. What is important to remember here is that NPI is context-based, and in some claims, you will never see certain provider types, and that is normal. Like, for instance, in Part A, you will not see care plan oversight organization NPI, prescribing NPI, primary care provider, and alternate service. And similarly, in Part B, you will not see attending physician or surgeon, operating, prescribing, primary care provider. That's important because in my practice, I often receive questions why certain NPI fields in the context of provider type, not fields. Well, this is why. Beneficiary is described uniquely by Medicare beneficiary identifier. It has been fully implemented as of 2020 by the legislature, adopted by US Congress. It was done because the previous identifier, he contained social security number, and it was subject to fraud and identity theft. So now Medicare cards contain 11 position number that is randomly assigned, which is Medicare beneficiary identifier. However, HICANs, as some of you familiar with, they are not going away. They are still used, quote unquote, behind the scenes, along with a beneficiary link key and beneficiary crosswalk. All that information is contained in the repository called Beneficiary in Cloud, and it has it all. We do receive it in the CDR. Reference codes, they refer to various reference data, such as diagnosis, procedure, codes, and revenue centers. They are maintained by regulatory bodies and infrequently change, usually quarterly, annually. Healthcare Common Procedure Coding System, or HCPCS, is produced by the CMS, and it's divided into two subsystems, level 1 and level 2. Level 1 is comprised of current procedure terminology codes and consists of 5 numeric digits. Level 2 identify products, supplies, and services not included in CPT. And CPT is the current procedure terminology codes. Unlike HCPCS, they are maintained by American Medical Association, and they offer doctors and healthcare professionals a uniform language for coding medical services. Revenue center code is the provider assigned revenue code for each cost center within a hospital for which a separate charge is billed. The cost center is essentially a division, a unit within a hospital, such as radiology, emergency room, pathology. And there is an exception. The revenue center code 0001 represents the total of all revenue centers included on the claim. These revenue centers codes are maintained by American Hospital Association. And there are around 400 of them. What else did I not cover? Well, this is a slide taken from the IDR, and it contains some extraneous information such as NDC, National Drug Code. This is relevant to Part D claims. It's outside the scope. And same goes for contract. Contract refers to healthcare prescription plans. And I think I covered here everything. We can go to the next slide. For some reason it is empty. I don't know why it happened. Oh, acronyms. Conceptual view. Next one, acronyms. Oh, okay. So these are acronyms that we used. And I believe this concludes my presentation.
Hey, Gennady, we actually did get a question on an acronym for CVM and what that stands for.
Conversion Medicare.
Okay, that's what the user had thought, but we just wanted to verify. Then we had a couple of other questions as well. So just going through. Oh, and then your resources as well. A
Yes,
reminder, we'll be
these
sharing
are
the.
these are
Go
important.
ahead.
Yes. If you interested in daily statistics of claims processing at CMS, do subscribe to the distribution list for so-called pulse reports. It's the first one. Second one, and I apologize, I didn't have a distribution list, but I do have a subject matter expert who can sign you up. It's a NCH updates distribution list. It's very important because, as I mentioned, it takes a long time for our legacy systems to get updated. But when they get updated, sometimes we have changes in data format, fields are added, definitions are added, valid values are added. So it's very important to stay on top of it. The third one is CMS data taxonomy. It's mostly for data architects. And the fourth is basically more reading on CMS fee-for-service providers. And last but not least, it's worth watching on YouTube, Life of a Claim, 1 hour overview of Medicare benefits and healthcare claims processing. It's definitely more informative than what you received today from me.
Okay, Gennady, are you ready for me to go to the next slide then?
Yeah.
Okay. Which slide? Mine. Oh.
It should be the last.
Okay.
Yeah.
Yep. And then I know there between the resources and all of the acronyms, just a reminder that the decks will be published on our Confluence space. So anyone can download those and take another look and then actually access all of the links and click straight from the deck. So we did have a couple of questions. One of them being, is the claim processing for Part D similar to Parts A and B?
It is actually different, and it will be a separate discussion on claims, Part D as in dog. And I happen to be a member of the team who wrote that entire Part D program back in 2005. So I'll be happy to cover that, but that requires a whole different presentation. But there are some similarities. They also have final action, and they also are subject to adjustments and deletions.
Our next question, why is there a direct flow of claims data in Prens bypassing the CWF from shared systems to the IDR and not the NCH? And then there's like a follow-up part as well.
Oh, let's go to that slide. I think it is slide 12 or 11.
Here, let me exit out and then we can scroll up. That would probably be easier.
Yeah.
This one?
13.
13.
13. Yeah. Yeah, because IDR is the main source of our claims. In fact, even though IDR was created much later than NCH was created in early 2000s, it is our flagship data warehouse. It was used by law enforcement many times to uncover major fraud schemes. And why I'm telling you all that is IDR is very powerful in terms of data processing, querying, and reporting engine, which could sit on top of it. and therefore it was decided that it needed to be updated daily, and therefore a separate feed was established directly from shared systems. But as you can see, IDR also receives an MQA feed on a weekly basis, and these are being reconciled. And if my answer is not satisfactory fully to the level of detail, I can get you more information from my colleagues at OIT who know everything about IDR. But this is what I know, and I can explain on high level.
Sorry about that. Gennady, we had a follow-up question while we're on this chart. Where will you put CDR in this chart for slide 13?
If I were to put CDR here, I would put it as another green rectangle with rounded corners next to NCH, because that's how we receive claims now. If you go to slide 19, you will see why.
Sorry, my mouse is
go
stuck
to
on my
slide 19 real quick, and yeah.
Okay.
So see, now we still receive a feed of all fee-for-service claims from the NCH. But the idea is to bypass it and receive the same data, but from CVM.
Okay.
Hope it makes sense.
At this point, we do have a couple of other questions. Just a reminder that if our questions did not get answered, we will be passing those on to Gennady after our session, just so we can stay on time, because I know we have another one right at 4 o'clock today. And people are cycling in and out of sessions as they have time between meetings. So we are going to wrap up session 8 at this point. And thank Gennady so much for a great presentation. And then our next session is going to start in just 1 minute, which is the CCSQ DNA Roadmap and Vision with Ken Howard, Alicia Hudson, and Justina Sardin from 4 to 5 p.m. And that is our final data camp session. So thank you so much to Gennady. I'm going to turn things over to them in just a minute. Take a quick break if you need it while I switch out slide decks.